it has been changed very recently, the label changed, and there is no more the indication of sorafenib tolerant due to real world evidence that established that regorafenib can be administered also to patients with prior intolerance to sorafenib. So we have regorafenib, we have cabozantinib with phase 3 data, both in second line and in third line. And we have ramucirumab, that is a monoclonal antibody anti-VEGF receptor 2 in patients with a high baseline AFP level. So these drugs have been approved after sorafenib because we have phase 3 data after sorafenib. In the US and in some countries, also immunotherapy is approved in second line. Pembrolizumab as single agent and nivolumab plus ipilimumab as a combination, mostly based on phase 2 data. And these options is not available in Europe. Also with the tyrosine kinase inhibitors, we know from exploratory analysis of the phase 3 trials that with a sequence of two tyrosine kinase inhibitors, starting from sorafenib or starting from lenvatinib, we may achieve overall survival, median overall survival up to 26 to 30 months. So this was the scenario before immunotherapy. Then we had the first positive or promising data from phase 1 and 2 trials of immune checkpoint inhibitors as a single agent. Here you can see a summary of the CheckMate 040 trial that tested nivolumab and the Keynote 224 trial that tested pembrolizumab. Nivolumab both in sorafenib naive patients and in sorafenib experienced patients, pembrolizumab only in patients previously treated with sorafenib. There are also some data in first line, but I'm not showing them. So based on this data, you can see here 29 months median overall survival in first line, 16 months in second line. Based on this data, then further trials have been conducted. But unfortunately, the phase 3 trials of nivolumab in first line and pembrolizumab in second line were negative. Here you can see on the left the CheckMate 459 that tested nivolumab versus sorafenib. The trial was powered to demonstrate the superiority of nivolumab versus sorafenib, but unfortunately, as you can see from the curves, there is no superiority. On the other hand, there was a clear benefit in quality of life. You can see on the bottom left of the slide that at each time point, the quality of life favor nivolumab versus sorafenib. In second line, pembrolizumab was tested in the Keynote 240 trial versus placebo, and unfortunately, there was benefit in overall survival of 3 months, you can see here, versus placebo, but based on the statistical design of the trial was negative. The subsequent or the parallel Keynote 394 trial that was conducted in an Asian population tested again pembrolizumab versus placebo after sorafenib or chemotherapy, that it is used in Asia, and the trial was positive. So there were a meta-analysis was conducted. It was pre-planned, the meta-analysis between the Keynote 394 and the Keynote 240, and also the meta-analysis demonstrated a benefit in second line versus placebo. So that's the reason why pembrolizumab is still approved by the FDA, and it is approved in other countries. However, it is approved after sorafenib or after chemotherapy. And meanwhile, I mentioned also that the combination of nivolumab plus ipilimumab is approved in the US in second line. I've just shown you that the first line phase 3 trial of nivolumab as single agent was negative, but the CheckMate 040 included different cohorts and also a cohort of patients treated with nivolumab plus ipilimumab. These are the updated results, updated at 5 years. And you can see that the median overall survival is 23 months in the primary analysis and confirmed with a longer follow-up, 22 months. So there is a clear evidence that the immunotherapy in some way works in patients with HCC. Then the same CheckMate 040 trial tested a triple combination, cabozantinib plus nivolumab plus ipilimumab. Actually, this triple combination has maybe some efficacy, but as you can see in the curves on the bottom right of the slide, there is no such difference compared to the combination of two drugs, nivolumab plus cabozantinib. So probably 3 drugs are too many in patients with HCC and previously treated with the other agents. So I mentioned that we have promising data from immunotherapy as a single agent. Then the phase 3 trials were mostly negative, except for the Asian pembrolizumab trial. Then we had again phase 2 data of nivolumab plus ipilimumab in second line. And here you can see the phase 1 and 2 data of durvalumab plus tremelimumab, so another combination of 2 immune checkpoint inhibitors. Again, this is a phase 1 and 2 trial. And this trial showed for the first time a new way to administer a combination of immunotherapy. So a single priming dose of tremelimumab, a single priming dose of anti-CTLA-4, followed by durvalumab, that is anti-PD-L1. And this regimen showed the highest efficacy. You can see here 19 months overall survival, and also that is not shown in the slide, a very good safety profile. On the right, you can see the biomarker analysis at day 15, and the single priming dose of tremelimumab led to an expansion of unique T cell clones and increased T cell proliferation associated with longer survival. So with a single priming dose of anti-CTLA-4, we reduce the adverse events that are associated to the anti-CTLA-4, we increase the efficacy, and there is also a translational part of the study supporting this combination. Finally, before moving to the phase 3 trials, the other possible combination was to the combination of immune checkpoint inhibitor plus multikinase inhibitors. Here you can see the phase 1b trial of lenvatinib plus pembrolizumab. And you can see in the waterfall plot and also on the curves, you can see median progression-free survival 9 months, median overall survival 22 months. So these data were really promising. Now, I'll show you the phase 3 data in a while, but just to summarize which types of combinations are tested or have been tested, because we are now new agents that are being tested, but have been tested so far. The combination of immune checkpoint inhibitor plus anti-VEGF, bevacizumab. Bevacizumab has an anti-angiogenic activity, but also immunomodulatory effects. The combination of 2 different immune checkpoint inhibitors, and the combination of tyrosine kinase inhibitors plus immune checkpoint inhibitors. And we will see that there will be some differences between multi-kinase inhibitor and tyrosine kinase inhibitor with a single target. So starting from the first positive phase 3 trial of immunotherapy and a combination of immunotherapy in HCC, we have the IMbrave 150 that tested atezolizumab plus bevacizumab, so anti-PD-L1 plus anti-VEGF versus sorafenib in 500 patients randomized 2-to-1 to immunotherapy versus sorafenib. The key eligibility criteria are very simple: locally advanced or metastatic or unresectable HCC, no prior systemic therapy. So this is a first-line treatment. And the stratification factors included the region, performance status, macrovascular invasion, and or extrahepatic spread, and baseline FP. Importantly, the trial had co-primary endpoints, overall survival and progression-free survival, and other secondary endpoints. The treatment was administered until loss of clinical benefit or unacceptable toxicity. The trial was presented at ESMO Asia in 2019 and published in the New England Journal of Medicine in 2020. And you can see here on the left, the survival curves. The hazard ratio was 0.58 with a p-value that was highly statistically significant. The median overall survival with atezolizumab plus bevacizumab was not yet reached at the time of the primary analysis. We had the medians for the progression-free survival on the right, and the median progression-free survival was 6.8 months versus 4.3 months. And also there was a benefit in terms of response, objective responses, with objective responses in approximately 30% of the patients. If we look, if we consider the response according to RECIST 1.1 or modified RECIST, there are some differences, but more or less 30% is the response rate with a long duration of response. Then the trial was updated, and the updated results were published last year in Journal of Hepatology. And you can see that now we have the median for the overall survival in patients who received atezolizumab plus bevacizumab, and the median overall survival is 19.2 months. That was the longest median overall survival observed until the publication of this data. The progression-free survival was confirmed around 7 months, 6.9, and also the response rate was confirmed 30% with a long duration of response of 18 months as median. In terms of safety, the most frequently observed adverse event was hypertension in 30% of the patients, but of grade 3 or 4, only in 15% of the patients. Then we have proteinuria and other events. But the most worrisome adverse event was bleeding, and in particular bleeding from esophageal varices potentially associated to bevacizumab. So all the patients should have received an upper endoscopy before starting treatment with atezolizumab plus bevacizumab, and if varices, in case of varices, the varices should have been treated before starting treatment with atezolizumab plus bevacizumab. And with the upper endoscopy and the treatment of varices, grade 3-4 bleeding events were similar in the two treatment arms, approximately 6%, both with atezolizumab plus bevacizumab and sorafenib. Another important point is related to the quality of life. And on the bottom left of the slide, you can see the curves of the median time of the quality of life, and the median time to deterioration in quality of life was much longer with atezolizumab plus bevacizumab compared to sorafenib, 11 months versus 3.6 months. So we have a trial that is positive in terms of efficacy with good safety profile and a benefit in quality of life. Then from 2020 until 2023, several exploratory analyses have been conducted. It's not important to go into the details, but it's important to mention that the efficacy and safety of the combination was confirmed in all subgroups of patients analyzed. And another important point that was already demonstrated for tyrosine kinase inhibitors, there is a correlation between AFP levels and prognosis, so and outcomes. So if during treatment we see AFP that increases, that can be a sign of lack of activity or less activity or reduced activity, but a decrease in AFP is frequently associated with a better outcome. Another trial that confirmed or supported the benefit of combining immune checkpoint inhibitor plus anti-VEGF is the Orient-32. This is a phase 3 trial conducted in China, so it's a specific population, only Chinese patients. But as you can see from the curves, the shapes of the curves are very similar to the YW2023. This trial tested sintilimab, that is another PD-1 inhibitor, plus bevacizumab biosimilar, again versus sorafenib. And as you can see, the results are very similar to the YW2023. So there is this has supported the rationale of combining immune checkpoint inhibitors plus anti-VEGF. The other combination is the combination of two immune checkpoint inhibitors. And the Himalaya trial tested the combination that I just mentioned with a single priming dose of tremelimumab plus durvalumab. This is called a STRIDE versus sorafenib. And also the trial included a durvalumab single agent arm that was tested for non-inferiority versus sorafenib. At the beginning of the trial, there was a fourth arm, then that was closed based on the results of the phase 1 and 2 trial. Then this fourth arm included the classical combination of 4 doses of anti-CTLA-4 and the anti-PD-L1, but the STRIDE regimen was the new way to administer tremelimumab plus durvalumab and confirmed its efficacy. An important difference between the Himalaya and the YW2023 trial is that in the Himalaya trial, patients with the main portal vein thrombosis, so VP4, were not included in the trial. Of course, the upper endoscopy was not required because we don't have anti-angiogenics in this regimen. Again, stratification factors are classical: macrovascular invasion, yes or no, etiology, HBV, HCV, others, and performance status, 0 or 1. The primary endpoint of the study was the overall survival. And here you can see that the combination of tremelimumab plus durvalumab, so the STRIDE regimen, was superior compared to sorafenib with a median overall survival of 16 months approximately. And the durvalumab single agent was non-inferior compared to sorafenib. If you look on the right, we have a landmark overall survival analysis that was pre-planned in the study. And you can see that it's important to focus on the STRIDE, less on durvalumab single agent, but you can see that the benefit in terms of survival increases over time. And at 3 years, we have 31% of the patients in the STRIDE arm alive. And this improvement or increase in the benefit over time is associated to the mechanism of action of the double immunotherapy combination. And very recently, so couple of days ago at the ESMO GI, Bruno Sangro presented the updated results at 4 years. And you can see that at 4 years, we have 25% of the patients alive in the STRIDE arm. This is the longest follow-up and the longest overall survival ever achieved and ever presented in patients with advanced HCC. So we have 1 out of 4 patients that are alive at 4 years. And another point, again, presented last week, is that there is a correlation between disease control and survival. So it's not important to achieve an objective response. Of course, it's important in clinical practice, but for to achieve a long overall survival, the stable disease, the disease stabilization is enough. If you look at the curves on the right, you can see STRIDE in dark blue and sorafenib in purple maybe, or reddish. Patients with disease control have the longest overall survival. Patients without disease control, so patients who progress, actually have a worse outcome. So it's important not only to achieve objective response, but also to have a stable disease. Coming back to the primary analysis, so I mentioned the primary analysis for the overall survival and this very recently presented data with an updated follow-up. There is no benefit in progression-free survival. This should be still better understood, but it's probably related to the mechanism of action. There is no benefit in progression-free survival, but there is a long-term benefit. As already mentioned, we have 25% of the patients alive at 4 years. In terms of objective response, the response rate is 20%, and we have also 40% of patients with stable disease, so 60% disease control rate, and these are the patients who benefit, who really benefit from the treatment. The median duration of response is long, 22 months, so patients who respond may have a duration of response that is almost 2 years. And the time to response is quite quick, rapid, 2 months. That is similar also with the other combination. In terms of safety, the only important point that I would like to mention that the percentage of patients who require the high dose of steroids to manage the immune-mediated adverse events was only 20%. With other double immunotherapy combinations, this percentage was up to 50%, and you are very well aware that steroids are not the best drug for patients with liver cirrhosis. So only 20% of the patients require the high dose of steroids to manage the treatment-related adverse events. And only 6% of the patients had immune-mediated adverse events leading to discontinuation of study treatment. You are very well aware that with tyrosine kinase inhibitors, we were used to see percentage around 10%, 15% of patients who stopped the treatment due to adverse events. Also, in terms of quality of life, there is a benefit. Here you can see the curves for the median time to deterioration in quality of life, and with both immunotherapy regimens, STRIDE and durvalumab single agent, the time to deterioration in quality of life is longer compared to sorafenib. Then we had other exploratory analysis, as already mentioned, for the IMbrave, and the efficacy and safety was confirmed in all subgroups of patients analyzed. Also, in terms of regarding the safety profile, there is a trend. This is not a demonstration, but there is a trend that, or potential association between immune-mediated adverse events and outcome. And I will show you later on that there is also in other analysis, there is an association between adverse events and outcome. This can be important in clinical practice. Now, these were the 2 most important phase 3 trials with immunotherapy combinations, and these both combinations are approved by most of the regulatory agencies worldwide. More recently, other phase 3 trials of immunotherapy have been presented, Here you can see the rationale 301 that tested tislelizumab, another PD-1 inhibitor, versus sorafenib as non-inferiority. And tislelizumab was inferior compared to sorafenib in terms of overall survival. So similar to the durvalumab single agent arm of the Himalaya. And we will see if we will have this option in clinical practice. Now, I mentioned that the combination of tyrosine kinase inhibitors plus immune checkpoint inhibitors have some problems, let's say. This is the first presented and then published trial, the COSMIC 312, that tested the combination of cabozantinib plus atezolizumab versus sorafenib. The trial included also a cabozantinib single agent arm. It's not important for this presentation. What is important is that the trial had a dual primary endpoints, so not co-primary endpoints, but dual primary endpoints, progression-free survival and overall survival. So if one of the primary endpoints was positive, the trial was positive. And here you can see on the bottom left of the slide, the primary endpoint of progression-free survival. This is the final analysis. Cabozantinib plus atezolizumab was superior compared to sorafenib, with the results that are very similar to the IMbrave 150, 6.8 months, the progression-free survival. Unfortunately, if you look at the top right of the slide, you can see the interim analysis for overall survival. The final analysis is still to be published, but the results are identical. And you can see that there is no benefit in overall survival. Sorafenib performed very well, 15.5 months overall survival, but cabozantinib plus atezolizumab performed with a median overall survival of 15.4 months. So this trial is formally positive, but this combination will not be further developed for clinical practice. So this is a statistically positive trial, but not clinically meaningful trial. The only important point is that in patients with HBV etiology, there was a benefit, a clear benefit, not only in progression-free survival, but also in overall survival. Actually, also with cabozantinib single agent in the registration trial, in the Celestial trial, we had seen a larger benefit in patients with HBV, so maybe it could be related to the tyrosine kinase inhibitor. Anyway, the combination will not have any development for clinical practice. And the other unfortunate trial was the LEAP-002 trial that tested the lenvatinib plus pembrolizumab versus lenvatinib single agent. I've shown you the data of lenvatinib plus pembrolizumab, the phase 1b data, with a median overall survival of 22 months. And here in the phase 3 trial, you have a median overall survival of 21 months, but with the lenvatinib single agent, the median overall survival is 19 months. So the trial was negative and there is no benefit in any of the efficacy endpoints. However, we have one trial that is positive with a tyrosine kinase inhibitor that is rivosiranib, also called apatinib, that is not a multi-kinase inhibitor, but is a small molecule directed against the VEGF receptor 2. So similar to ramucirumab, but a small molecule and not a monoclonal antibody. So it seems that maybe multi-kinase inhibitors do not work well with immune checkpoint inhibitors. This trial was conducted mostly in China, mostly in Asia, sorry, not mostly in China, mostly in Asia, and only 17% of the patients were from non-Asian countries. The trial enrolled a similar population, so patients with advanced or unresectable HCC. And the patients were randomized between carlizumab anti-PD-1 plus rivosiranib versus sorafenib. The trial was positive, both in progression-free survival and overall survival. And you can see here the overall survival is very long, 22 months. And sorafenib performed very well also in this trial, 15 months. So probably the median overall survival that we can now achieve with the sorafenib is 15 months and not 10 months. And with lenvatinib is 19 months and not 13. And then there is also a benefit in response rate. However, because there's a however, in the safety summary, you can see that grade 3-4 treatment-related adverse events were observed in 80.5% of the patients, and treatment-related adverse events leading to dose modification or interruption of any treatment component, again, were observed in 80.5% of the patients. So I don't know if this combination will be approved by the FDA or EMA, because only 17% of the patients were from non-Asian countries. But if it will be approved, then we will have this combination in clinical practice. Probably it will be a combination for patients in very good clinical conditions, because the safety profile is not so good. The tolerability is not so good as I've shown for atezolizumab plus bevacizumab or durvalumab plus tremelimumab. Now, it's important to understand, but you are very well of that we cannot do cross-trial comparisons. And here you can see a table presented last year when the Himalaya trial was presented the first time at ASCO GI 2022, comparing the IMbrave150 and the Himalaya. It's not important to look at the efficacy data that are different in different trials, but if you look at the bleeding events in the sorafenib arm, you can see that in the IMbrave150, you have 17% of patients with the bleeding events, any grade. And in the Himalaya trial, 5%. So 17 versus 5 with the same drug, sorafenib. And if we look at the grade 3-4 bleeding events, as mentioned in the IMbrave, they are approximately 6%. And in the Himalaya, 1.6%. And it's always sorafenib. So this difference, or these differences, are not related to the drug, but are related to the population included in the trials. In the IMbrave150, patients with the main portal vein thrombosis were included, and they are patients with the highest risk of bleeding, and they were not included in the Himalaya. This is important, and not only for the bleeding risk, but also to understand that it's impossible to compare the different trials because they included different populations. And this table included also the other positive trial, the canalizumab plus rivoceranib trial, also the negative or clinically negative trials. And again, it's not important to go into the numbers in terms of outcome, but if we look at the baseline characteristics of the patients in the canalizumab trial, the 310, not 312, this is a mistake, this is a 310. Asian patients were 83%, in the IMbrave 40%, and the Himalaya 40%. Etiology, HBV 75% in the canalizumab trial, 48% in the IMbrave, 31% in the Himalaya. So it's really, really difficult to compare because these trials tested different regimens, included different populations within different inclusion. And also the trials had different inclusion criteria, for instance, the main portal vein thrombosis. So how can we choose in clinical practice? Because in the US, Europe, both atezolizumab plus bevacizumab and durvalumab plus tremelimumab are approved. In Italy, the STRIDE regimen is not yet reimbursed, but it will be in the near future. So how can we do in clinical practice? We have the phase 3 data, but also maybe we need something else in the clinics. Generally speaking, we choose our treatments in oncology based on biomarkers, and that can be tissue biomarkers or serum biomarkers, or we can decide based on patient and disease characteristics or drug characteristics. Unfortunately, for HCC, we don't have tissue biomarkers. This slide that is very confusing includes the translational analysis from the phase 1 and 2 trials. So from the first trials of nivolumab and pembrolizumab. And there was a kind of signal of highest activity of immunotherapy in patients with the activated immune system. So patients maybe with the highest levels of PD-1, PD-L1, or with an inflammatory signature. But anyway, in the end, there was no clear correlation of, for instance, PD-L1 expression and activity of immunotherapy, or inflammatory signatures that can be used in clinical practice. So all the patients might benefit from immunotherapy. From the atezolizumab plus bevacizumab, both the phase 3 trial, the IMbrave, and the prior GO3140, so the phase 1b trial, a very comprehensive biomarker analysis was performed and published last year in Nature Medicine. This is just the graphical abstract to show that different analyses were included, but there are very nice results, scientifically speaking, but nothing that can be used in clinical practice. The only biomarker that we can use in clinical practice for HCC is AFP, that we were already used to use for patients treated with tyrosine kinase inhibitors. And here you can see that there is a correlation between AFP changes over time and response. Most patients with objective response had decrease in AFP levels. And there is also a correlation between AFP changes over time and overall survival and progression-free survival. This is something that can be useful in clinical practice when we follow our patients, but not something that we can use to select the treatment or to select one regimen or the other before starting systemic therapy. Several scores have been performed or been created and then validated. This is one, the CRAFT score, that is very simple. It includes just AFP and CRP, and this is a predictive score for outcome on immune checkpoint inhibitors, but once again, it doesn't help to select one regimen or the other. So patients with, here you can see the different scores, low, medium, high, have different prognosis when treated with immune checkpoint inhibitors, but regardless of the regimen. Another important point was the development of anti-drug antibodies. Patients treated with immunotherapy may develop anti-drug antibodies. So is there any correlation between anti-drug antibody development and prognosis and outcome? On the left, you can see here the data from the IMbrave, and on the right, the data from the Himalaya. Actually, more patients in the IMbrave develop anti-drug antibodies, but after adjustment for some imbalances, there were no correlation between the development of anti-drug antibodies and outcome. And in the Himalaya trial, less patients develop anti-drug antibodies, and there is no difference in outcome based on the development or not development of anti-drug antibodies. So also these potential biomarkers cannot be used in clinical practice. So in the end, in clinical practice, we have just the clinical characteristics. In the slide, you can see a summary of the potential clinical characteristics that we may consider in clinical practice: bleeding or risk of bleeding, cardiovascular diseases or cardiovascular risk factors, autoimmune diseases, and liver transplant. For the risk of bleeding, we have to do the upper endoscopy, the EGD, for patients who we decided to treat with bevacizumab, and we have to evaluate the risk of bleeding that can be increased by concomitant medications, anticoagulants, antiplatelets, or other aspects, or low platelet count related to liver cirrhosis. We have to consider the cardiovascular diseases, maybe hypertension. Uncontrolled hypertension can be a contraindication for antiangiogenics, but we also know that hypertension during treatment can be associated with better outcomes. So we have to well evaluate the cardiovascular risk profile. Immunotherapy should be used with caution in patients with severe autoimmune disorders. For instance, hypothyroidism is not contraindication for immunotherapy. Lupus, for instance, is a contraindication. And then, at least so far in clinical practice, immunotherapy is an absolute contraindication in patients with prior liver transplant. Maybe this will be changing in the future. There are ongoing trials, but outside of clinical trials, I do not recommend the use of immunotherapy in patients with liver transplant. Other aspects that we may consider in clinical practice are liver function. On the left, you can see the data from the IMbrave, on the right from the Himalaya. Actually, in the IMbrave, it seems that patients with ALB grade 2 do not benefit from atezobev, but this was an exploratory analysis post-hoc, not pre-plan. In the Himalaya, it seems that there is a benefit regardless of baseline liver function. And the liver function remains stable over time in both trials. So there is no deterioration of liver function related to the treatment. Another important point, very much debated, is the potential association between etiology and efficacy of immunotherapy. In the slide, you have a summary of the most recently presented or published data. On the top left, post-hoc analysis of the IMbrave. Here you have only patients treated with atezolizumab, not patients treated with sorafenib. Progression-free survival on the left and overall survival on the right. And then you can see that there is no difference according to etiology. On the bottom left, the adjusted analysis from the Himalaya. At the beginning, at the first presentation of the Himalaya data, it seemed that patients with the HCV etiology did not benefit or benefited less from the STRIDE regimen. Actually, even if the trial is random, is stratified for etiology, there were imbalances in extrahepatic spread and ALB grade in the HCV subgroup. And after adjustment for imbalances and also confirmed at the 4-year analysis, there is no difference in terms of efficacy according to etiology. So also HCV positive patients benefit from the treatment. And on the right, there is the most recently published meta-analysis by Tim Meyer and Anne Vogel as a letter to Journal of Hepatology. And you can see that the diamonds are all in favor of immunotherapy. So hepatitis B, hepatitis C, non-viral, and overall there is a benefit from immunotherapy. So I don't think, actually, I strongly support the use of immunotherapy regardless of liver cirrhosis etiology. Moving to the other things that we can consider in clinical practice, I already mentioned that there is a potential correlation between adverse events or immune-mediated adverse events and outcomes. These are two cooperative efforts, international efforts, that demonstrated in a retrospective series the correlation between treatment-related adverse events and outcomes. So this is important in clinical practice because we have to treat the adverse events and to avoid to stop treatment due to adverse events. Now, if we start with the immunotherapy, atezolizumab or durvalumab, then how can we sequence? Because we have a phase 3 data only after sorafenib. This was the position paper published 2 years ago, and the recommendation was to use multi-tyrosine kinase inhibitors and VEGF receptor 2 inhibitor as per off-label availability. However, we have some data. Here you have the real-world evidence data or a Markov model for sorafenib or lenvatinib after immune checkpoint inhibitors, and the efficacy and safety are comparable to those reported in the phase 3 trials. And the same is true for the drugs that we were used to use in second line after sorafenib, like cabozantinib, regorafenib, and ramucirumab. These are exploratory analysis or real-world evidence, and the efficacy and safety are very similar to what was reported in the phase 3 trials. The only trial presented so far is this phase 2 trial of cabozantinib after immune checkpoint inhibitors, presented by Stephen Chen. So this is a trial from Hong Kong and South Korea, and the data for cabozantinib, both in terms of efficacy and safety, are similar to the data of cabozantinib after sorafenib. So it seems that we can use tyrosine kinase inhibitors after immune checkpoint inhibitors. Another option where this is allowed by the local regulation is the rechallenge. So patients who receive an immunotherapy, single agent or combination, and then receive another immunotherapy. And the efficacy data summarized here, response rate, disease control rate, time to progression, the safety data are very similar both in the first immunotherapy and second immunotherapy. So if allowed, this is something that can be done in clinical practice. Now, moving to the conclusions. This is the BCLC 2022 update. And as you can see, in the first line, there are both of the options, atezolizumab, bevacizumab, durvalumab plus tremelimumab. And then second line, third line, the recommendation is to enroll patients in clinical trials because we need to generate data after immune checkpoint inhibitors. The ESMO guidelines are not very much updated. They included just atezolizumab plus bevacizumab. They have been updated in 2021. But it's important to notice that after atezolizumab plus bevacizumab, we don't have a standard of care. We have options, and all the drugs are grouped together. So the guidelines do not help to choose in clinical practice. And if you look at the magnitude of clinical benefit scoring by ESMO, both YW2023 and Himalaya have the highest score of 5 that is related to the benefit in overall survival and the benefit in quality of life. So, in conclusions, in terms of therapeutic options available for patients with advanced HCC, atezolizumab plus bevacizumab and durvalumab plus tremelimumab, according to the STRIDE regimen, are first-line standard of care. STRIDE provides a long-term survival benefit with a 4-year survival of 25%. Sorafenib and lenvatinib are approved first-line or now second-line systemic agents, and sequential treatments may achieve median overall survival up to 26 to 30 months. Regorafenib, cabozantinib, and ramucirumab for AFP high patients are standard of care after sorafenib, but we now have data also after immune checkpoint inhibitors. Conclusions on how to choose and sequence. We don't have many factors to choose and sequence, to define how to choose and sequence. Predictive biomarkers for immunotherapy as PD-1, PD-L1, MSI, tumor mutational burden are infrequently found in HCC, and the correlation with the outcome is unclear. Different immune scores have been developed, like the Crafty score that I've shown, but they don't help to select one regimen or the other. Adverse events, immune-mediated adverse events, and treatment-related adverse events, and AFP changes correlate with outcomes, so they are something that we can use during treatment to better follow our patients. There are few data based on which we cannot choose immune checkpoint inhibitors, like patients with prior liver transplant. And in clinical practice, we have to base our decision on the data from clinical trials and also the real-world evidence. In the future, we have a durvalumab single agent and tislelizumab single agent that demonstrated non-inferior overall survival versus sorafenib. We will see if we will have these options in clinical practice. Camrelizumab plus rivosiranib showed improved overall survival and progression-free survival versus sorafenib in a mostly Asian population. Again, we will see if we will have this combination in clinical practice. We have new combinations in phase 3 trials from the early to the advanced setting, and we will see. And just one slide for the early stage HCC. The IMbrave050 is the first positive trial ever in HCC in the adjuvant setting. The IMbrave050 tested atezolizumab plus bevacizumab for 12 months versus a surveillance or a follow-up in patients treated with a surgery or curative ablation and with the high-risk features. And the trial is positive, presented at the ACR this year. We don't have the medians yet because the data are very early, not preliminary because the trial is positive, but we have a hazard ratio 0.72, p-value that is statistically significant, but we don't have the medians yet. So we will see more mature results in the near future. Open issues, there are many. These are just some of them. We need more data on baseline characteristics and sequencing to help select first-line therapies and also second and beyond lines. We need biomarkers because we don't have biomarkers except for AFP. And considering the scenario that is more and more complex, the multidisciplinary approach remains key in treating patients with HCC. And these are two studies that show that regardless of the stage or the treatment, that the multidisciplinary approach is associated with improved survival in patients with hepatocellular carcinoma. Thank you so much for your kind attention. This is our multidisciplinary team.
Well, thank you very much, Lorenza. This was beautiful. It was a beautiful lecture. I really enjoyed.